I don't guess I have to tell you that health care is a major issue and a subject of sometimes problem and sometimes not only in our community, but in our state and our country and the world too. But we're going to talk about health care that affects you and me. And we have as our guest Mr. Jason Spacek, who is Vice President for Channel Marketing for Blue Cross and Blue Shield of Kansas City.
That's correct.
I'm delighted to have you.
Thank you for having me.
Okay, and I've already told him we got to talk about some of these hard subjects because it really is a problem, and you know that that is the case. Healthcare is a problem. Figuring out what they're talking about is a problem.
There's no shortage of challenges, certainly, that we're working towards, and affordability.
Does Blue Cross and Blue Shield have somebody that answers those kind of questions? I don't know that.
Yeah, so we have folks for individuals as well as groups. We have folks that man our phone lines, both from a customer service and a sales perspective, to help folks navigate the challenges of healthcare, as you alluded to, and get those questions answered on a regular basis.
Well, you know, I'll just use myself as an example. I'm on Medicare. I bet you didn't guess that.
I didn't. I would have never guessed.
Yes. Well, I have, my tie-in policy is Blue Cross and Blue Shield. And since I live in Johnson County, you are my provider. And on Medicare, I didn't have Part D because, fortunately, knock on wood or whatever, I'm healthy. So I just added Part D. I honestly didn't know which Part D to add. My Blue Cross and Blue Shield is the policy that I had before I retired, which I was able to maintain, which I'm very pleased that I was able, because I've always had Blue Cross and Blue Shield. But I didn't know what to do, and I'm not, I never thought I was dumb anyway. And so finding out those things is important to have somebody to ask a question of.
Absolutely, and that's something that we've advocated for a long time at Blue Cross and Blue Shield, is to get help, you know, and you don't have to do this thing alone. Sure, we have a website that you can buy from, and you can buy directly from us, but we partner a lot with our broker community, independent third-party brokers that are, you know, paid by the carriers. They don't cost the individual user anything.
But do you have to have Blue Cross and Blue Shield to have the question answered, or can somebody call if they have a question?
So certainly they can call us, our sales department, at any time and ask questions that they may have.
But you answer from the Blue Cross Blue Shield perspective. I mean, they have to understand that.
Certainly,
so,
and
yeah.
then obviously we have a whole customer service team for our existing policyholders that have questions about their plan usage.
And that is really important. Now, this is a problem that when I knew you were coming, I said something, and they said, ask him this. A child, 26 years old, she happens to be 26, she lives in her parents' home, she pays her own way, but her job does not pay enough so she can pay rent on her own. Does she have to list her parents' income or only her own when applying for Obamacare?
Well, I'm certainly not a tax attorney or tax advisor, but generally speaking, the way it works is that depending on how you file taxes is how your coverage will work. So if she's filing under her parents' taxes, then that income would all count together as a household as it relates to the ACA.
She probably is emancipated, so she doesn't.
Yeah, so if she does not, then only her income would be counted in her eligibility towards her health care coverage. And
toward the subsidy. And
correct.
Now, Missouri doesn't get that subsidy because they don't have a state health care program.
Well, subsidies are actually currently available both in Kansas and Missouri.
I know they're available in Kansas.
There's Supreme Court litigation going on right now to understand the constitutionality of that, because Kansas and Missouri both default to the federal marketplace for that coverage to be
But Kansas does have a Kansas health care system.
Correct. Yeah. So both of them, though, have obligated the federal exchange to be the place where people can buy that coverage and get their subsidies.
So when is a decision going to be made? Is it on the docket for this season?
Last we heard, I think, sometime early this summer, June, July time frame, something like that.
Well, you know, there are an awful lot of people without health care. Let's talk about hourly workers. They make a minimum wage. They don't get any benefits. How can they get health care, affordable health care?
Well, that's where the subsidies are supposed to help out. So the subsidies begin for people at 100% of the federal poverty level, which is about $11,000 a year in income. and then those folks are more heavily subsidized. Folks all the way up to 400% of the federal poverty level, or about $45,000, are eligible for some level of subsidy as well. So anyone between that $11,000 and $45,000 as a single individual would qualify for some element of subsidy assistance on a sliding scale. The one challenge that we do have in Missouri and Kansas is that the states elected not to expand the Medicaid program, which was part of the original ACA design. And so you do have some folks that unfortunately fall in a little bit of a donut hole there that can't get coverage through the ACA, but also do not qualify for the current Medicaid program since it has not been expanded.
Now, do they have to pay a fine because they can't get the, you're supposed to pay a fine if you aren't covered by health insurance? I mean, that's a problem.
That is, yeah. And a lot of folks, unfortunately, will be getting a surprise come tax time. We're obviously right in the throes of tax season.
A lot of those people don't pay any tax.
Well, that's true. And so you wouldn't have a tax liability unless you actually,
Yeah, see, it is a large donut hole.
Yeah, and I don't know the exact numbers. Like I said, anyone below that $11,000 a year income could potentially fall into that donut hole, if you will. But anyone $11,000 or above is eligible for coverage and some subsidy assistance to help them pay for it.
Well, healthcare is really expensive. If you're in the hospital, and I notice, and there's a lot of paperwork associated with healthcare now. And I have noticed, in fact, my physician has become a concierge physician. And you pay a certain amount of money per year. They don't mess with any paperwork. It's completely separate from health. They don't care whether I have health care or not.
Mm-hmm.
Talk about that a little bit. I mean, there are so many different facets to this whole thing, and concierge physicians are becoming more and more prevalent.
Yeah, you certainly are starting to see some physicians sort of branch out into some different approaches.
Mm-hmm.
The physician I had been going to has done the same thing and said, we're not taking insurance anymore, we're just doing this kind of monthly fee, almost like a gym membership in a way, where
That's right.
You pay a flat fee.
I pay a yearly fee, yeah.
And you go, however many times you want.
Mm-hmm.
We certainly don't necessarily advocate that, because the insurance that we provide obviously covers a lot more than just your primary care activity. But what we've heavily invested in is our patient-centered medical home program. And what that is it has some similarities to what you're talking about from a concierge perspective, where providers are more accessible than ever before to their patients. They also serve as kind of the quarterback of that patient's care, where they're coordinating all the extra services or hospitalizations or following up with you on your medications and those sorts of things. So there's some new standards of care that are out as part of our patient-centered medical home program.
See, there's the thread to pull out, new standards of care. And I think that if those can be provided, then it makes it more attractive to have a regular physician and use that health care.
Yeah, no doubt. And part of that model too is that we're also trying to shift some of the payment mechanism, right? Because historically in the United States we've had a pay per service model where doctors are frankly incented to see more and more people and do more and more things,
right.
and so
hurry them through faster.
So part of the challenge for us is how do we shift some of that to more of a fee for value model, where we're paying doctors to help keep people healthy and keep them out of the system as much as possible, because they're healthy and don't necessarily need it. But
well,
you've got
and
to
now
make
you're
sure
talking
that
about
balances.
wellness and prevention.
That's right.
So, does Blue Cross and Blue Shield? How do you put that message out? I guess that's what I'm asking.
Yeah, well, there's lots of ways that we try to do it today. So we obviously heavily invest in community partnerships that foster health and wellness as central to their mission. We also have health and wellness programs that we provide to our large group customers. It's a program called A Healthier You that has incentives and awareness and opportunities for people to pursue healthy lifestyles and those sorts of things. And then on the other end of the spectrum, we have disease management and case management programs who are working with some of our folks with chronic conditions to help manage those conditions and hopefully keep them
How do you get
on the
that
path to
word
wellness.
out? I didn't know you had that.
A lot of it's outreach, right? So a lot of it we work through those employer groups and their HR departments to make those things aware. We do a lot of on-site screenings of employees, so we'll come to your work site.
Yeah, but you're talking
and do
about
those sorts of
businesses
things
now.
as well.
How do you let me know as a person who is, well, I'm semi-retired. How do you, I mean, the message needs to get to me too.
Yeah, a lot of that, it's more challenging, right, on a one-on-one basis. There's lots of information out there that people are pouring through, but a lot of our welcome materials, we try to onboard folks and let them know about the programs that are available to them. And then for some of the folks dealing with chronic conditions, it's more of a need-to-know basis, right? As you start to fall into that category, we will do outreach with professional nurses
Now,
and
pre-existing conditions can no longer keep a person from getting health insurance, is that correct?
That's correct. So coverage is available year-round for folks. Again, there's no medical questions on the application. Anyone can get coverage as they need it.
Let's talk about COBRA a little bit, because there are a lot of people that have lost their jobs or have been furloughed for, you know, for one, and they're on COBRA, and that lasts, what, 18 months, I think. When they get through with COBRA, can they roll back and be a regular recipient of the policy that they had before COBRA? Or is that gone now?
Yeah, so with COBRA is actually somewhat lessened in necessity with the ACA now, because losing your
ACA is
Affordable Care Act. I'm sorry, we get very acronym heavy sometimes at Blue Cross and Blue Shield, but with the Affordable Care Act now, COBRA is actually less of a critical element. It's important for folks who want to maintain that exact policy they had while employed, and so it's good for that. Under COBRA, they certainly can. But then with the ACA, you get another option, which is losing your coverage at your place of employment qualifies you as a special enrollment event under the ACA. And so with the ACA, you know, we have an annual enrollment period that lasts for a couple of months every year. But if you lose your coverage at work, you can enroll at any time in an individual plan under the ACA. So you can pick up coverage at any time.
Yeah, but a lot of people that are on COBRA have gotten a divorce, and they were on their spouse's policy. So it isn't a matter of going to work, it's a matter of they were on their spouse's policy for it. So they cannot, the answer is, they cannot assume ownership of that policy after the COBRA is over.
Correct, but the good news, or since we're talking about divorce, maybe not good news, but divorce is also a qualifying life event. So there's a series of them that allow you to enroll in coverage under the Affordable Care Act at any time: a marriage, a birth of a child, a divorce, a loss of coverage at work. All of those things would qualify you to then go out onto the marketplace and enroll in coverage at any time.
Let's talk about medicines. This is a real problem because we are a society of medications, I have decided. And there are numbers, great numbers of people who take medicines, and as new medicines come on the market that are much more effective and with fewer side effects, that's the good part, as you say. The bad part is they're very expensive, and that often they are not covered under the medicine part of a person's policy. And I'm not talking about Medicare people now, I'm talking about people who are right there on, and what do you do about that? What if you have to have that medicine? What do you do? Yeah,
we have obviously a medical advisory committee that constantly reviews our formulary to make sure that the right drugs and medications are part of that. But you're right, as new things come along, those prescriptions can get very expensive.
Oh, they're very expensive. And generic medicines don't do, and other choices are not an option.
Yeah, and we're seeing it right now. There's a hepatitis C drug that's come out.
I read about that.
That's a gigantic expense. That's covered today with us. But we are working obviously to make sure that that's meeting the needs of the patients, as well as, again, are there generic alternatives that can help keep costs down? Are they as effective? And so that it's just really an ongoing, level of diligence that we have to have.
Okay, so the answer is you have to constantly review the medications that you pay for.
As a plan, certainly we constantly review from a medical efficacy perspective, from a cost perspective. Are there alternatives? As you know, medicines are constantly rolling off of patents, and so generics become available. So we constantly have to be.
And if there are no generics and another option isn't available, then do you sometimes make an exception?
Typically, those things will be covered, right? If there's no other alternative and it's been reviewed as medically viable for that patient, and that's going to help that particular condition, then typically those things will always be covered as part of your health.
How long does it take to make that decision?
Well, typically we review our formulary on an annual basis, and then ultimately there's other reviews, obviously, as new things come to the market. So it's really a continuous process, but typically major adjustments are made on an annual basis.
Seasonal workers. They are, and I think we answered it sort of with the hourly workers, but seasonal workers are a whole different ballgame. They just usually fall out of the system.
Yeah, and that a lot of it, again, from an ACA perspective, is that, those folks would report income just like a part-time or a full-time worker would, and if that income level would qualify for them for subsidy assistance, they would qualify for it and could get coverage that way, and so that would be.
So let's pull that out again. The Affordable Care Act is very important in people's lives that are having some difficulty or other with their health care coverage.
Certainly, it certainly streamlined the process. You mentioned earlier that there's no pre-existing conditions. Anyone at any time can get coverage, no matter the conditions or health status that they're in. It again extends the opportunity from an income perspective to those that perhaps affordability was an issue before through the subsidy program. So it certainly expanded the program to include many more individuals than before.
Which is a segue into another issue, and that is health care costs. Some necessary, some unnecessary. And I read someplace where those costs amount to about 1/3 to 1/2 of the cost of health care. The costs that are really unnecessary, in other words, having a C-section when it's not necessary, really necessary, or operations that are sort of a pro forma that are not always necessary for people. Can you discuss that a bit?
Yeah, sure. I mean, I think certainly unnecessary medical costs are a concern amongst the entire industry.
Well, yeah, and it would lower the cost of the health care.
Certainly, yeah. And part of what we see in the United States is that we're fortunate to have amazing technological advances and new procedures and technologies make health care improvements, and we're living longer lives, and all that's great, but it also comes at a cost, right? And you also find areas where perhaps it's abused or overused in that regard. So it's really, though, it's not an easy solution, unfortunately. I'd love to pull a lever and make it all go away, but there's really, I think we all have a part to play in it. As insurers, we have to do more to make sure we're educating people on who the best doctors are, where the lowest cost options are. We've got a long way we can do to educate the public on transparency of costs and procedures and those sorts of things. I think the public obviously has a piece in it in keeping themselves as healthy as possible and choosing healthy lifestyles and making smart choices. And then the provider community as well, in terms of making sure they're delivering care according to standards and not overusing or over-recommending and those sorts of things as well.
Well, and hospitals are crying because, if you need health care, you need health care. And people get these staggering bills and they have no way to pay them.
Right.
So therefore, eventually, they're written off, along with the emergency rooms, who treat a lot of people for whatever reason, whether they're new Americans and they are working on their citizenship, not working on, I mean, there are all kinds of people that come to emergency rooms, people who don't work, people who are out of the system for one reason or another. So the emergency rooms are screaming too.
Yeah, it's certainly a challenge without, like I said, an obvious and easy solution. It really requires a collaborative effort from across the industry to really address the challenges we have.
So given that challenge, what exactly do you see, where is the healthcare going in this country?
Yeah, I think it's at a bit of a crossroads, but I think, again, where we're choosing to invest our time and resources and through our PCMH program, Patient-Centered Medical Home Program, we're trying to shift that conversation.
Tell me what that is.
That's the program we talked about a little bit earlier with our primary care physicians, who we really see as the core and central to everyone's care. Having that core patient and primary care provider relationship is critical, we think, to keeping people out of the ER or on a path to health and wellness, making sure they're managing their chronic condition, adhering to their medications, all of those things. We see the primary care physician being central to that objective. And so shifting that approach from a fee-for-service to a fee-for-value payment to those providers to give them some incentive to keep their populations healthy. That's happening as we speak. We have hundreds of doctors in the Kansas City area that are now part of that program. And again, we're building upon those incentives for those doctors.
So let's talk a little bit about how they bill then.
Or traditionally today, it's still very much a fee-for-service overall. So they're still billing as they see patients and those sorts of things. But at the same time, we're trying to shift some of that paradigm a little bit to give them incentive opportunity to manage their populations.
Now talk about the incentives a little bit.
So those come with, basically, are you as a primary care physician doing a better job of managing your population through their health conditions and their health status than the average
How do you
doctor
assess
is doing
that?
through lots and lots of medical data, we can obviously see, what the rates of admissions for that or readmissions for that primary care doctor, how well they're managing their chronic condition, their diabetics and those sorts of things. We obviously have lots of data around how well those populations are being managed, and we're trying to share some of those savings essentially with the providers themselves, again, to encourage them to not just, again, see patient, but to actually manage that patient and share in that patient's journey through hopefully a healthier lifestyle.
So many of the physicians now are selling their practices to hospitals. Does that make a difference?
Not so much in our patient-centered medical home program. We partner with independent primary care practices as well as hospital-owned primary care practices. So we work very collaboratively with both, and that doesn't.
Is there much? Do you notice much difference in the?
I don't think so. I mean, at least not from where I sit anyway. But I think again, we're trying to work with those doctors to implement some of these new standards of care and really be available and effective for their.
How do you work with hospitals? Because people. I hear people say, "Oh, I don't want to go to the hospital. I get an infection." They talk about MRSA, and it's true. What do you do to work with hospitals to cut? And they just had an article in the paper about hospitals and the rate of infections or the number of infections that because they have to report those.
Yeah, we do things with the patients one-on-one. With patients that are coming up on discharge from hospitals. We have a transition to home program that leverages.
No. Let's go back with the hospitals. What do you do with the hospitals to cut down when they have a heavy rate of infection? The people are in the hospital. That costs money, and it's a drain on the healthcare system as well. So do you work with hospital to see to it that the operating rooms are, is there any kind of conversation there?
We don't get as involved in that from a health plan perspective. I think there's other probably entities that I think are better suited to manage hospitals and
right.
safety records and those sorts of things. But we certainly work on the
but
patient side.
But that does throw the cost up.
Certainly, yeah. I mean, and I think over time those hospitals will, usually self-correct those things if they do pop up here and there to make sure that they're, because ultimately if they're not managing their populations well and people are getting sick in the hospitals, they're just not going to frankly be competitive for long. And so we try to focus more on the patient side as they transition out of that hospital to make sure they're following up on their doctor's orders, they're getting their appointment follow-ups that they need, they're adhering to the medications they've been prescribed and those sorts of things. That's really the area that we're focused on with the
Let me ask you this. Do you track in any way the cost of health care for individuals? In other words, if you look at person A, you can't check everybody, but do you spot check? Look at person A. Their health care bills have gone up exponentially, because they've been in the hospital, they've done this, that, or the other. Do you look at that and say, now why is it that those health care costs have gone up exponentially? Yes, they're getting older, but that doesn't mean they're necessarily sicker. Yeah. So you have to look at, do you look at that?
So we don't necessarily come at it straight from a cost perspective. Certainly cost is an outcome of somebody becoming more and more unhealthy. We tend to look at it more from the health status side, and so that's where our disease management and case management staff come on board, and we have reporting and indications that folks are emerging diabetics or haven't gotten their A1C values evaluated and maybe pre-diabetic or hypertension and those sorts of things. And so
obesity is a big problem.
Obesity is an issue, certainly. So we look at all of those things, through a lot of reporting and modeling that we have, and can see when people are starting to trend in those directions, and that's when we usually bring our support staff on board to help.
Well, I guess I keep pushing because I really believe that the cost of health care is getting just out of proportion. And I don't know how much longer we're going to be able to afford it if those costs keep going up. Yeah,
it's a challenge. I think it's certainly a fight worth having, and one that we're certainly engaged in on a regular basis. And again, I think it requires really the responsibility of the individual patients themselves to choose active lifestyles and to make improvements there. It takes the health plans to make sure, again, we're pointing people in the right direction of where quality care can be received as well as where affordable care can be received, and then the providers themselves, again, to continue to evolve how they deliver care as well. It's going to take all of us pulling in the same direction.
Well, a system of patient rewards wouldn't be such a bad idea.
Yeah, and we see some of that. We've done a little bit of that on the health and wellness side with some of our groups, as I mentioned earlier. We've given some incentives for people, choosing healthy lifestyles or maintaining health, or those sorts of things. We've done incentive programs in the past. The jury's still out a little bit on what level of incentive you need to have to get someone to really stand up and pay attention. But we're certainly continuing to put resources towards.
Well, the biggest incentive is to cut their payment down. Some of these people, in fact, I was just talking to a fellow yesterday, and he works for a large company in Kansas City, and he pays, I believe, $250 a pay period. He has 2 pay periods a month, so that's $500 a month for a family plan. That's a lot of money.
Yeah, it's certainly, the costs are not getting any
cheaper. And you can have one child for 15 and still have the same family.
Right.
plan.
Yeah, the costs certainly aren't getting any cheaper. Again, that's where the focus on solutions is going to be critical and key to all of it. And we're exploring some of that as well too, with giving folks perhaps discounts for choosing certain providers and those sorts of things. Again, there's lots of
having one child instead of 5.
Well, yeah, and that's a lot where the Affordable Care Act comes in a lot. There's pricing almost on a per person basis as opposed to kind of these bundled or family rates and those sorts of things.
Well, healthcare isn't just as easy as saying healthcare. It's more than 2 words. It's a lot of moving parts.
That's right. Yep, and a lot of disparate parts, which has been part of the challenge historically, is how do we get all these pieces moving in the same direction together, and that's going to be the key.
Maybe this is an odd question, but does Blue Cross Blue Shield have a long-range plan?
Oh, certainly. We're always, engaged in planning, both from a physician perspective as well as, many other perspectives as well,
so
too.
Let's talk about that. Where is healthcare going in this country?
Well, again, I think that's,
a long-range plan.
We talked a lot about it, but I think, again, investing in those primary care practices, I think we see as central to our approach for healthcare in the future. Again, making sure you've got that relationship with your primary care doctor as the center of all of your coverage, and that way that relationship can help guide all of your healthcare planning from that point forward, and then providing incentives to those doctors, again, to keep you healthy and not just keep churning you through the office is really central to our plan.
Well, it is, but I do think that long-range planning is very, very important, because I have to be honest with you, if we keep on going the way we're going, as far as costs and the intricate movement through healthcare, we are heading, I think, towards socialized medicine in this country. Now, I'm not telling you that's good or it's bad, but it's certainly different.
Yeah, and we're doing everything that we can to try to keep those costs as curbed as possible.
I keep harping on costs because
it's a real issue, and it's an issue for folks out there that are watching that again have challenges with affordability. It's a challenge for all of us, whether you have employer coverage or whether you're buying it on your own. Affordability continues to be an issue for everybody, and so everything that we can do, as I mentioned, transparency earlier, focusing on pointing people to the right direction. Healthcare is one of the few industries where you don't necessarily know how much it costs to go see your doctor, or how much it costs to go get your knee replaced, or those sorts of things. And so how do we make sure all the data that we have, we can use to empower the public to make smart decisions with where they're getting their coverage.
That's right.
Been lots of studies that the most expensive places to go aren't necessarily the highest quality. And so how do we make sure we're shining the light on that for customers so they can make smart decisions?
That's right.
With
and
their
that
healthcare.
takes a lot of advanced planning and attention to detail, and knowing what parts are moving and what parts are getting ready to move.
Yeah, absolutely.
So yeah, it takes a lot of people, a lot of thinking, a lot of thought, but you and I are concerned, so I'm going to push him a little bit, and he's a good guy, so he took it well, and I have to say that I have a great big thank you, Jason Spacek, who is the Vice President for Channel Marketing at Blue Cross and Blue Shield of Kansas City. And thank you for being on the hot seat a little bit.
You're welcome. It's a noble cause and one worth fighting for sure.
It certainly is. Good health care is something that we have decided that we all deserve in this country, not just for a few of us, but for all of us.
Correct.
So thanks, Jason. And thank you for being with us, because after all, it is our community. We'll see you soon again.